Bismillahirrahmanirrahim. Today we have got Dr. Bakhtawar. She will be talking about treatment of testicular cancer. Please.
Assalamu alaikum. My name is Dr. Bakhtawar, and today my topic of presentation is treatment of testicular cancers, and my moderator is Dr. Yasir Lagari. So the learning objective of today's presentation are introduction, staging, prognosis, risk groups, treatment, and management of residual mass. So the germ cell tumor accounts for the 95% of the testicular cancers. Germ cell tumor may consist of one predominant histologic pattern or a mixed pattern or mixed germ cell tumor types. Non-seminomatous germ cell tumor common peak incidence is 15 to 35 years. In most series, the ratio of seminoma to non-seminomatous germ cell tumor is approximately 1. For treatment purpose, there are two broad categories: recognized pure seminoma, and which contain non-seminomatous element, and all other which are termed as non-seminomatous germ cell tumors. So the difference between the seminomas and non-seminomatous germ cell tumors are: seminomas are more likely to present with localized disease compared with non-seminomatous germ cell tumors. Seminomas display relatively indolent growth or longer natural history, rarely spread through the bloodstream beyond the retroperitoneal lymph nodes, like other areas, liver, lungs, bones, or brain. And stage 3 metastases more frequently occur in men with non-seminomatous germ cell tumors. Seminomas typically do not have marked elevation of serum beta HCG and never have an elevated alpha fetoprotein. In contrast, beta HCG and alpha fetoprotein are elevated in majority of men with non-seminomatous germ cell tumors. Seminomas are exclusively sensitive to radiation therapy, while non-seminomatous germ cell tumor are more radio resistant. Seminomas with elevated serum alpha fetoprotein are considered as mixed germ cell tumors, and these should be treated as non-seminomatous germ cell tumors. Prognostic groups for testicular cancer. So here in the staging, T is for the tumor size, N for the nodal stage, and M for the metastasis, and S is for the serum tumor markers. In stage 0, there's PTIS. There's no lymph node involved. There is no metastasis, and serum tumor markers are within normal range. In stage 1 is further classified in stage 1A and 1B. In stage 1, there will be the tumor size will be T1 to T4, but no nodal or metastatic involvement, or the serum markers will be normal. In stage 1A, the T will be T1 and no nodal or metastasis. In stage 1B, the T will be T2 to T4 with no nodal or metastasis involvement. In stage 2, there will be PT1, any PT to PTX, but there will be involvement of the serum tumor markers, could be normal or could be elevated, and there will be involvement of lymph nodes. And in stage 3, there will be any PT, any nodes, and metastasis will be present, and tumor markers could be normal or could be elevated. So here is the staging simplified. In stage 1, there is stage 1A and 1B, and disease is localized to the testis, and with tumor markers will be within normal range. In stage 2, it is stage 2A, 2B, 2C. Disease is spread to the retroperitoneal lymph nodes, and that serum tumor markers could be elevated or could be in normal range. And in stage 3, there is stage 1A, B, and C, and disease is metastasized to the distant organs like lungs, liver, and bone. So simply, the stage 1 is localized disease. Stage 2 is disease is spread to the retroperitoneal lymph node, and stage 3 is disease metastasized to the distant organs. Treatment modalities, we have surveillance, chemotherapy, radiotherapy, and lymph node dissections. So in surveillance, there is no active treatment given to the patient following radical orchiectomy. We follow the patient on history and physical examination, tumor markers, and CT scans. But the issues with the compliance with the surveillance is that compliance. If the patient is non-compliant, he live far away from your hospital, then you cannot offer him surveillance. And there is extensive imaging, and the patient is always in fear that the disease could progress. And surveillance is always offered for stage 1A disease. There is limited role of surveillance in management of seminomas and non-seminomas. So, and the other treatment modality is radiotherapy. In radiotherapy, radiation therapy uses a beam of high energy rays or particles to destroy the cancer cells or slow their growth. It do it by targeting the DNA and prevents the replications of cells. The seminomas are radiosensitive and is used to treat pelvic and retroperitoneal lymph node disease. So the dose is 20 to 30 Geier and duration is 3 to 4 weeks. We give ipsilateral para-aortic and para-aortic nodes and iliac nodes. But the complication with radiotherapy, the side effects are acute gastrointestinal symptoms, which occur in 60% of the patients. And these are the nausea, vomiting, diarrhea, and chronic GI systems symptoms, which are experienced by 5% of the patients. And risk of non-germ cell malignancies. If there is non-germ cell malignancies, then there's little role of radiotherapy. For chemotherapy for testicular cancers, we have different regimes for chemotherapy and chemotherapeutic agents. The most commonly utilized is the BEAP, which is the bleomycin, etoposide, and cisplatin, carboplatin, EP, etoposide, and cisplatin, TIP, paclitaxel, ifosfamide, and cisplatin, VEIP, which is the vinblastine, ifosfamide and cisplatin, and VIP, etoposide, ifosfamide, and cisplatin. The dosage is the most common used therapy regime is cisplatin, etoposide, and bleomycin. That's why I have written just their dosage. Cisplatin is given 20 milligram per meter square for days of 1 to 5 days. Etoposide is given 100 mg per meter square for 1 to 5 days, and bleomycin 30 mg for one on day 1, 8, and 15, and plus hydration. Total days of interval are 21 days. So that side effects of chemotherapy, the common side effects are bleomycin is associated with pulmonary toxicity, dermatologic toxicity, and Raynaud's phenomena. Etoposide causes myelosuppression, secondary leukemias. Cisplatin causes the electrolyte disturbance, specifically magnesium, and nausea, vomiting, nephrotoxicity, ototoxicity. Phosphomide causes neurotoxicity, hemorrhagic cystitis, nephrotoxicity, and myelosuppression. Paclitaxel causes neuropathy, myalgias, arthalgias. Vinblastine, myelosuppression, and neuropathy. Carboplatin causes electrolyte disturbance, myelosuppression, and ototoxicity and nephrotoxicity. Gemcitabine causes myelosuppression, flu-like syndrome, and oxaliplatin causes myelosuppression and neurotoxicity. If patient present pre-therapy with these symptoms or present with these symptoms after therapy, then we have to stop these medication and start and think something more. So, and for stage 1 disease, for stage 1 seminomatous germ cell tumor, it is further we give treatment on the risk factor, which predicts the recurrence following orchidectomy. It depends on tumor size and invasion of reticulum. If the size is less than 4 centimeter and there is no invasion of reticulum, then it is low risk. And if the size is more than 4 centimeter or invasion of reticulum, then it is high risk. So for low risk, we will follow the active surveillance. We will offer the patient active surveillance, and for high risk, we will offer the patient carboplatin 1 dose or radiotherapy. The EUA recommendation are we should fully inform the patient about the all available management options, including surveillance or adjuvant therapy after orchidectomy, as well as treatment specific recurrence rate and acute and long-term side effects. Offer surveillance as the preferred or management option if resources are available and the patient is compliant. Offer 1 dose of carboplatin at area under curve semen or if adjuvant chemotherapy is considered. Do not perform adjuvant treatment in patient at very low risk of recurrence. Like if the size is less than 4 centimeter and there is no involvement of ready testes, then you should give only active surveillance. Prefer this. Do not routinely perform adjuvant radiotherapy. Adjuvant radiotherapy should be reserved only for highly selective patients, not suitable for surveillance and with contraindication for chemotherapy. So for clinical non-seminomatous germ cell tumor, they are again the treatment is on the risk factors, whether the patient is high risk or low risk. The risk factor for non-seminomatous germ cell tumors are the lymphovascular invasion, predominance of an embryonal carcinoma component in the primary tumor, pathologic tumor stage T3 or T4. If any one of these is present, then the patient is considered as high risk, and if none of these are present, then and the patient is considered as low risk, and the relapse rate is 10 to 14%. So the recommendation for treatment of stage 1 non-seminomatous germ cell tumors are: inform the patient about all management options after oophorectomy, surveillance, adjuvant chemotherapy, and retroperitoneal lymph node dissection, including treatment-specific recurrence rate as well as acute and long-term side effects. Offer surveillance or risk-adapted treatment based on the lymphovascular invasion. Discuss one course of cisplatin etoposide bleomycin as an adjuvant treatment alternative in patient with stage 1 non-seminomatous germ cell tumor if patient are not willing to undergo or comply with surveillance. So for the low risk, surveillance or adjuvant chemotherapy is recommended. Stage 1A PT1 no vascular invasion low risk offers surveillance if the patient is willing and able to comply. Offer adjuvant chemotherapy with one course of cisplatin, etoposide, bleomycin in low risk patient not willing to undergo surveillance or not suitable for surveillance. If patient is high risk and patient is having high risk disease, then adjuvant chemotherapy, active surveillance, and retroperitoneal lymph node dissection should be offered. All three options are associated with a greater than 99% disease specific survival, with no single best option for all patients. For stage 1B, high risk offer a recommendation are offer adjuvant chemotherapy with one course of beep or surveillance and discuss the advantages and disadvantages with the patient. Offer surveillance to patient not willing to undergo adjuvant chemotherapy. Offer nerve sparing retroperitoneal lymph node dissection to highly selective patients, only those with contraindication to adjuvant chemotherapy and not willing to accept surveillance. Primary lymph node dissection should be advised in men with post-pubertal teratoma with somatic malignant component. So this was stage 1, and in stage 2 disease, the seminomas, for seminomas stage 2 disease, we can offer radiotherapy, chemotherapy, or retroperitoneal lymph node dissection. For radiotherapy, the reported relapse rate is 9%, and the radiation dose is recommended. Radiation dose is stage 1 is 30 Gauss, stage 2B is 36 Gauss. 5 years relapse free survival rate for stage 1 is 92%, and stage 2B is 90%. Chemotherapy, the first line should be preferred option is chemotherapy for stage 2 seminomatous carcinomas. The chemotherapeutic agent first line is BEEP 3 cycles, but if the patient is having pulmonary disease, then EP should be advised. 4 cycles etoposide and cisplatin should be given. It is preferred over radiotherapy. It has similar efficacy to radiotherapy and has lower long-term side effects. Primary RPL-ND lymph node dissection, it causes the removal of all ipsilateral periaortic lymph nodes, and it provides staging as well as therapeutic advantage, but it is performed in few centers due to the problem of retrograde ejaculation. So in this, this is the summary of the stage 2 seminomas. If it is clinical stage 1, then the preferred option is chemotherapy, 3 cycles of bleomycin, etoposide, and cisplatin, or 4 cycles of etoposide and and cisplatin if there is contraindication to bleomycin. And alternatively, if there is a contraindication or the patient doesn't want chemotherapy, then alternative is the radiotherapy. Total dose is 30 Gauss to the periaortic and ipsilateral iliac lymph node, and then we will follow the patient. And if the patient is clinical stage 2B, then again the preferred option is a chemotherapy. And if the PEEP 3 cycles, and if contraindication to bleomycin, then EP4 cycles. And alternatively, in stage B, we should give radiotherapy 30 cycle plus there is extra booster dose to the lymph nodes, and then we will again follow the patient. And non-seminomatous germs for stage 2 non-seminomatous germ cell tumor. The non-seminomatous germ cell tumors are again, the treatment is again decided on the pathological and clinical staging. And in clinical staging, we will see first the tumor markers. If the tumor markers are normal and the patient is in stage 2, the lymph nodes are less than 2 centimeter and normal tumor markers, then preferred option is nerve sparing RPLND. But if the patient doesn't want to go undergo surgery, then we can offer him chemotherapy, 3 cycles of BEEP or 4 cycles of EP, or we can also offer him surveillance. If the patient is reluctant for going any option, then we can offer him surveillance. Because again, if the tumor markers are normal and the stage is 2B or 2C, the lymph nodes are more than 2 centimeter, then the preferred option is chemotherapy. In stage 1A, the preferred option was RPLND, but in stage 2B and 2C, the preferred option is chemotherapy. 3 cycles of BEEP or 4 cycles of EP. If there is residual, then we will follow the patient. If there is residual mass, then post chemotherapy RPLND is recommended. Okay, if the patient is
whenever we are talking about stage 2A, whenever there are raised tumor markers, the first preferred option is to go for the chemotherapy. And when it's normalized, then we are supposed to go for the.
I agree. Then पीछे करो कीमोथेरेपी प्रेफर्ड लिखा हुआ है ना पीछे पीछे करें नर्व स्पेयरिंग आरपीएनडी लिखा हुआ कीमोथेरेपी तो मेंशन नहीं है यहाँ पे ट्यूमर मार्कर बड़े होंगे तो फिर हम इनको कीमोथेरेपी देंगे बड़े नहीं होंगे तो फिर हमारे पास 3 ऑप्शन है वो आगे आपको उसमें चार्ट में नजर आ जाएगा
if the tumor markers are elevated and it is clinical stage 1A, 1B or 1C, we will prefer chemotherapy over RPLND. This is the answer to your question, that if the tumor markers are elevated, then the prefer whether the patient is having stage 1 or 2 or 1A or 2B or C, it is chemotherapy is preferred. The goal is to prevent the distant metastasis and residual mass more than 1 centimeter require post-chemotherapy RPLND. Post-chemotherapy residual mass is if less than 1 centimeter, then we can offer surveillance to the patient. On pathologic stage 2, non-seminomatous germ cell tumor, it is based on the pathological findings within the retroperitoneal lymph nodes retrieved. If the pathologic stage is 2A, active surveillance rather than chemotherapy is preferred. And if there is pathologic stage 2B, then adjuvant chemotherapy, 2 cycles of EP or BP are given. So this is after RPLND. We have pathological stage after RPLND. So this is treatment is after RPLND. So, but if the patient present with bulky disease, then first we have to go for the tumor markers are raised and there's bulky lymph nodes, then first we will go for the chemotherapy, then we will do the pathologic staging and again to so it is summarized now here again. If the patient is clinical stage 2A and the markers are positive, then chemotherapy is given. And if the clinical stage 2A and markers are negative, either we can give nerve sparing RPLND, and see if pathological stage 1, then follow up of the patient And if it is the pathological stage 1A or B, then either we can offer surveillance or beep maximum 2 cycles. And if the patient is reluctant for undergoing chemotherapy or nerve sparing RPLND, where then we can offer follow up after 6 weeks, and again we will do the CT scan. And if the disease is progressive in nature, then we will go for tumor markers. If tumor markers are positive, then 3 cycles of beep and resection of residual tumor. If tumor markers are negative, then nerve sparing RPLND or chemotherapy is given. Okay, or if the disease is non-progressive, then nerve sparing means the disease is at where it was, then nerve sparing RPLND is given. And if there is regression after 6 weeks, then we can follow the patient. Okay, the general approach to advanced disease, stage 3 disease. Advanced or disseminated testicular germ cell tumor, metastasis to retroperitoneal lymph nodes or beyond, in most cases either stage 3 or stage 2B or 2C. Men with abnormal tumor markers alone are treated as same as the stage 3 due to the risk of occult metastasis. Patients with primary mediastinal or retroperitoneal germ cell tumors are also categorized in the metastatic lesions. Okay, the stage 3 treatment is further depends on the prognostic based staging system for metastatic germ cell tumors. And there are the 3 groups: good prognosis group, intermediate prognosis group, and poor prognosis group. In good prognosis group, for seminomas, for non-seminomas, the 5-year survival, progression-free survival is 90%, and 5-year survival is 96%. Patient which come under this criteria are the patient having testis or retroperitoneal primary disease, no known pulmonary visual metastasis, and the tumor markers are within S1 level, which are AFP less than 1000, beta HCG less than 5000, and LDH less than 1.5 into the upper lower limit. And seminomas, for good prognosis seminomas, the 5-year survival rate is 89%, and 5-year survival is 95%. And the patient come in this criteria are any primary, no known pulmonary or visual metastasis, normal AFP, any beta, any HCG, or any LDH. For intermediate prognosis group, for non-seminomas, 5-year progression-free survival is 78%, 5-year survival is 89%, and any patient come testis or retroperitoneal primary, no known pulmonary visual metastasis, if the tumor markers are within the S2 or S3 level. And in seminomas, 5-year survival is progression-free 79%, and 5-year survival is 88%. And the patient come in this criteria are the any patient with any primary site, non-pulmonary visual metastasis, normal AFP, any HCG, and any LDH. For poor prognosis, there is no poor prognosis for seminomas, but for non-seminomas, 5-year progression-free survival is 54%, 5-year survival is 67%. And the criteria is mediastinal primary, non-pulmonary visual metastasis, and tumor markers within S3 level. So for seminomatous germ cell tumor, clinical stage 3, for good prognosis risk group, we offer beep 3 cycles, and if the patient is there's contraindication to bleomycin, then EP 4 cycles. And for intermediate prognosis risk group, beep 4 cycles and VIP 4 cycles. Limited role of radiotherapy or RPLND is primary treatment. Okay. For non-seminomatous germ cell tumor, clinical stage 3, for good prognosis group, bleomycin, etoposide, or cisplatin 3 cycles, and etoposide and cisplatin 4 cycles. And for intermediate and poor risk prognosis risk group, bleomycin, etoposide, and are given 4 cycles, and VIP 4 cycles. We can remember like this that for stage 3 we have to give only we can go for chemotherapy, either PEEP or EP. So this is the risk stratification, summarizes risk stratification and initial chemotherapy for men with metastatic germ cell tumor. We will first evaluate the histologic evolution after orchiectomy. When we get the pathological report, if it is seminoma and tumor markers are normal, means AFP is within AFP is not elevated and beta HCG is mildly elevated, then we can say that it is seminoma, confirmed seminoma, and uh, then we will divide it into good risk or intermediate risk. If it is in good risk, metastasis is limited to the lymph nodes, then 3 cycles of beep or 4 cycles of ep. If it is in intermediate risk, which means that metastasis to other organs and other organs than lungs or lymph nodes, then 4 cycles of beep are given. And if it is seminoma and tumor markers are elevated, then it is treated as non-germ cell tumors. So for non-seminomatous germ cell tumors, risk stratification is based upon the tumor markers and the primary site. For good risk, if all which include testicular or retroperitoneal primary, serum AFP less than 1000, beta HCG less than 5000, and LDH less than 3 times the upper lower limit, metastasis limited to lymph nodes and lungs, then we will offer 3 cycles of beep or 4 cycles of ep. If it is in intermediate risk group, testicular retroperitoneal lymph node, metastasis is limited to the lymph nodes and lungs, and one or more criteria is present, S2 or S3, tumor markers are within the S2 or S3, then 4 cycles of beep or 4 cycles of VIP are given. And in poor risk group, 4 cycles of beep or 4 cycles of VIP are given. So for the recommendation for the treatment of metastatic germ cell tumors are: treat low volume non-seminomatous germ cell tumor stage 2A and B with elevated markers like good or intermediate prognostic risk groups with 3 or 4 cycles of cisplatin, etoposide or bleomycin. It is the strong recommendation. The weak recommendation is the nerve sparing retroperitoneal lymph node dissection when performed by an experienced surgeon in the specialist center. In the recommended initial treatment in the stage clinical stage 2A without elevated tumor markers. Repeat staging after 6 weeks before making a final decision on further management in patient with small volume clinical stage 2A less than 2 centimeter and with negative tumor markers. Treat metastatic non-germ cell tumor stage more than stage 2C or stage 3 with an intermediate prognosis with 4 cycles of standard beep. In metastatic non-seminomatous germ cell tumor with a poor prognosis, treat with 1 cycle of beep or cisplatin, etoposide, and ifosfamide in case of poor lung function, followed by tumor marker assessment after 3 weeks. Continue the same schedule up to a total of 4 cycles with favorable marker decline. With unfavorable decline, initiate chemotherapy intensification. Perform surgical resection of viable more than 1 centimeter residual masses after chemotherapy for non-seminomatous germ cell tumor when serum tumor levels are normal or normalizing. Initially offer cisplatin-based chemotherapy according to the IGCCG prognostic groups, or alternatively radiotherapy to seminoma patient with stage 2A or B, and inform the patient of potential long-term side effects of both treatment options. This is the weak recommendation. Treatment of the seminoma stage 2C and higher with primary chemotherapy according to the classification IGCC classification of bleomycin, etoposide, and cisplatin, 3 cycles in good prognosis, and beep 4 cycles in intermediate prognosis is the strong recommendation. So after treatment, after giving the initial treatment, and what will be the management of the residual mass if we treat the patient, and after follow up we offer him CT scan, and on CT scan there is again mass. Then we have following option: if there is the mass is less than 3 centimeter, we could observe it on imaging and tumor markers. But if the lesion is more than 3 centimeter, then we should go for FDG PET scanning. It tell us the avid lesion. If repeat PET in 6 weeks to avoid false positive result, means we should not hurry for FDG PET scan if the patient has been offered chemotherapy, then we should wait for 6 weeks, and then after the last cycles of chemotherapy 6 weeks, then we should repeat we should do the FDG PET scan. If no activity is observed, then and if there is no activity, then observation on imaging and tumor markers are recommended. If there is on FDG, the lesion is more than 3 centimeter, then we can offer salvage chemotherapy or radiotherapy, or we can go for retroperitoneal lymph node dissection. But it would be difficult, and it is due to extensive fibrosis. It is very difficult, and it should be performed in high volume center. Management of non-seminomatous germ cell tumor residual mass. If for non-seminomatous germ cell tumor, we does not went for FDG PET scanning. After chemotherapy, we'll do CT scan, and if on CT scan the residual mass is more than 1 centimeter, then the surgical resection is recommended. If residual mass is less than 1 centimeter, then we can observe the patient, or we can offer him surgical resection. And the surgery, when indicated, should be performed within 6 to 8 weeks after the last chemotherapy cycle, and bilateral nerve sparing RPLND is the standard option. So this is the whole summary of what we have learned today. The management of seminomatous germ cell tumor following a radical orchiectomy. The diagnosis is based on the pathological confirmed pure seminoma and tumor markers when there is no elevation of AFP. Then we will go for after histopathology report, we will go for the CT chest and CT pelvis and abdomen for staging purpose. After staging, if there is no evidence of metastasis, no retroperitoneal lymph node retroperitoneal lymph node present, then we will offer active surveillance. If the lymph node are involved, then we will do the staging and stage 2 and extents of disease. If the lymph nodes present are less than 2 centimeter, either we can offer surveillance or low dose radiotherapy. If the lymph nodes are more than 2 centimeter, then we will offer chemotherapy, which is BIP 3 cycles or EP 4 cycles. If there is metastasis beyond the lymph nodes, and then for advanced germ cell tumor, we will, for intermediate risk group, we will offer BIP 4 cycles. And if there is no metastasis beyond lymph nodes and lungs, then it is in good risk group, and we will offer 3 cycles of BIP or EP 4 cycles. So this is the summary of the management of non-seminomatous germ cell tumor. So after evaluation, after having the histopathology report and tumor markers and CT scanning, if the patient, if there are retroperitoneal lymph nodes involved based on the imaging, then we will go for the tumor markers. If the tumor markers are not elevated, then it is in stage 1 or B, and we will, for stage 1, we will look for lymphovascular invasion, predominant embryonal carcinoma component, predominant embryonal carcinoma component, primary tumor stage more than 2, then yes, we will offer the patient adjuvant chemotherapy, BIP 1 cycle, or we can offer him active surveillance or RPLND. But if lymphovascular invasion, all these risk groups, risk factors are present, then active are not present. Sorry, I'm confused. If they are not present, then active surveillance is offered. If present, then active surveillance along with chemotherapy and RPLND, we can offer all the options to the patient and discuss with him or her. And if if the tumor markers are elevated after orchiectomy, then we will look for how much they are increased, and if they are in S3, tumor markers are within S3 level, then we will go for BIP 4 cycle or VIP 4 cycles. If not, then we can give BIP 3 cycles or EP 4 cycles. And if there are any lymph nodes is more than 2 centimeter, then again we will give him a chemotherapy, offer him chemotherapy. And if the disease is stage 3 disease, treatment for advanced germ cell tumor, which are the chemotherapy, will offer him chemotherapy. Follow-up of follow-up of seminomas. After when we offer the patient surveillance and he is agree with surveillance, then what we should do, we will do the we will offer the patient to follow up every year, twice yearly, with tumor markers, and CT scan is done twice in the first year, and in second year, and in after 2 years, in that second year, the tumor we will ask the patient to do tumor markers, repeat tumor markers twice, and CT scan twice, and in the and year 3 we will ask the patient to have 2 visits and twice tumor perform the tumor markers twice with CT scan at 36 months, and after 4 and 5 year the tumor markers should be done once, and the CT scan should be done at 60 month, and further management is according to the patient disease. Follow-up of non-seminomatous is for recommended minimal follow-up for non-seminomatous germ cell tumor clinical stage 1 on active surveillance is the patient in year 1. There's extensive follow-up for non-seminomatous germ cell tumor is due to the aggressive nature of the disease. So the tumor markers are, the patient is advised to for tumor markers 4 times yearly with chest x-rays twice and CT scan twice. In year 2 we will ask him for tumor markers 4 times in a year, chest x-rays twice, and CT scan at 24 months. And at year 3, twice the tumor markers and chest x-ray 1, and CT scan at 36 months. And in year 4, tumor markers 1 to 2 times, and at 60 month chest x-ray, and CT is done at 36 months. And after at year 4, 1 to 2 times tumor markers and x-rays, the CT scan and x-rays are reduced as the progression, is the patient is disease-free survival is improved. For recommended minimal follow-up after adjuvant treatment or complete remission for advanced disease, the modality is in year 4, in year 1, we will advise 4 times tumor markers, chest x-rays 1 to 2 times, and CT 1 to 2 times with thoracic CT 1 to 2 times. In year 2, 4 times tumor marker, once chest x-ray, CT scan at 2 years, and CT chest at 2 years. And year 3, twice tumor markers and chest x-ray once, and CT once, and thoracic CT 1. And then it is depend on the progression of the patient. Thank you.